Hello, my name is Ken Lipstock. Welcome to the Lipstock LASIK and Cataract Center website. In this section, I'm going to talk about cataracts and cataract surgery. There are a wide variety of surgical approaches to cataract surgery. Hopefully, by the end of this presentation, you will know which approach is best and why. Questions I will answer today are: what's a cataract? And what's the most advanced form of cataract surgery? Topical anesthesia versus block anesthesia, and laser-assisted cataract surgery versus ultrasound technique in cataract surgery. Also, can I eliminate my need for eyeglasses after cataract surgery? And what's astigmatism, and how can I fix it? And what's presbyopia, and how can I fix that? To do that, first let's look at the eye anatomy. The front window of the eye is called the cornea, and that bends light rays which enter through that and then through the pupil, which is an opening in a muscle, the iris, inside the eye, which is the colored part of the eye. And right behind the iris sits the lens. That also bends light rays. And the lens is suspended in its position with a spider web-like structure made of thousands and thousands of microscopic string-like structures that attach to the inside wall of the eye. Now, all the way in the back of the eye, you have the retina, and the space between the lens and the retina is filled with a clear gel called vitreous. The retina is a cellophane-like structure that lines the entire back wall of the eye, and it's made up of millions of nerves that funnel into a cable-like structure called the optic nerve. And the optic nerve goes back through the brain to the visual part of the brain, so the message reaches the visual part of the brain via the nerves of the retina through the optic nerve and then back to the brain. The white wall of the eye is called the sclera. So the eye is a two-lens system. The cornea and the lens both bend the light rays, so ideally they come to a sharp focal point right on the retina. A cataract is a clouding of the lens. And so when the lens gets cloudy as we age, at first there are no symptoms, but eventually images become blurred and distorted. A cataract is not a disease. Why do I say that? Because everyone by the age of 60, and most people by their mid-50s, has some discoloration to the lens, which would be a cataract. However, with early lens discoloration, there are no symptoms, and everybody gets it. And so, really, it's not a disease. It's sort of like getting gray hair. You know, everybody gets it. Early on, it starts very slightly, and it very gradually increases over the years. But the cataract does always progress. As I said, with the beginnings of a cataract, there are no symptoms, but eventually symptoms do occur, and the earliest symptom usually is glare, and halos, and starbursts at night, with difficulty driving at night, especially in the rain. Eventually, just general blurred vision, both at distance and near, occur. You may find that the glasses prescription changes and you need to change the glasses, and that helps for a while. And some patients may notice some fading or yellowing of colors, but usually the progression of the cataract is so slow and the change in the perception of colors so gradual that it goes unnoticed until the dramatic change once the cataract is removed. So when you have a cataract, at first we just observe it, and with an early cataract we just do a regular eye exam once a year and check that. Sometimes we'll be changing the eyeglass prescription, and eventually cataract surgery will be needed to be done. The rule of thumb for when it's a reasonable time to have cataract surgery is when the visual difficulties due to the cataract begin to interfere with activities that you like or need to do. So, for example, a truck driver with glare at night may have surgery earlier than someone who doesn't even drive at night. The glare to them would obviously interfere with their work, and it's a moot point if you're not driving, if that's the only symptom you have at night is the glare. However, you need to keep in mind that if you wait really long and let the cataract progress to where it's really advanced, then the cataract not only becomes much cloudier, but it also becomes much denser and more difficult for the surgeon to dissolve with the ultrasound device, and therefore that increases the risk of the cataract surgery. So there's no reason to do it if there are no symptoms, and usually at that stage the cataract's not going to be anywhere near being too dense to remove. But some patients, usually out of fear of the surgery, just put it off until they can't see anything, and then in that way they seem to create their own problems because they waited so long that they increased the risk of the surgery. My job is to help guide you in regards to that and sort of nudge you along if you're holding off, but the lens density is starting to look a bit suspicious, that it may cause some problems. Usually, the vast majority of times, patients ask me to remove the cataract well before it getting to that stage. Here are some simple statistics on cataract surgery. More than half of Americans over the age of 65 will undergo cataract surgery. It's half of Americans. That's a lot of people. Cataract surgery then is one of the safest but most commonly performed surgeries in the United States. More than 3 million Americans have the procedure every year. In our office, we usually do surgery on patients from their latter 50s to the latter 80s. A little unusual to do it in the early 50s, let alone in their 40s. And a few years ago, we did a study review of our charts out of curiosity just to see what was the average age we were doing cataract surgery. And in our office, it turned out to be exactly 70. Almost all surgeons in the Richmond area and elsewhere, including myself, do cataract surgery in this general way. First, your eye will be treated with some form of anesthetic prior to the surgery, so you will feel little, if any, discomfort. Then, a tiny microscopic incision is made to allow a small ultrasound instrument about the size of a pen tip to break up the cloudy lens into tiny particles and remove it from your eye. This technique is called phacoemulsification. Prior to the technique of phacoemulsification being invented, the cataract was removed entirely through a large 1-inch incision, usually on the superior part of the eye where the white heat hits the color part of the eye, and it required stitches, microscopic stitches, to close that large incision. In 1967, Charlie Kellman, a young surgeon at that time practicing in New York City, invented the technique of phacoemulsification. The story goes that he was getting his teeth worked on and the dentist was using ultrasound to clean his teeth, and he jumped out of the chair and said, "I got it," and he then said, "I'm going to use that to try to dissolve the lens instead of removing the lens in its entirety." So that's when everything began, because with this technique we were able to now be using a 2.5 millimeter incision compared to that 1-inch incision, which was a huge step forward in the recovery and many aspects of the procedure. At that time, with that technique, early on, there were problems as Charlie worked through the problems, and early adapters of the surgery worked through those problems. It caused, among other things, much corneal edema, patients requiring corneal transplants afterwards, and so the majority of the surgical community viewed Charlie in a very negative way, and he lost his hospital privileges at a prestigious hospital in New York City. But as with so many pioneers, it takes a certain personality to persevere. I think the surgeons who really wanted to slow him down had some very valid points. But regardless of that, it took years for this technique to be perfected to the point where by the early 90s it was becoming widely adapted. And today just about nobody uses the older techniques. It's the technology as well as the techniques has really been perfected to a beautiful, elegant procedure. Now, years later, with everything in perspective, Charlie Kellman is the father of modern-day cataract surgery and looked at as one of the most important cataract surgery or ophthalmology surgical giants in the field in the last 100 years. So when we look at Dr. Kellman's technique, you could think of the lens sitting behind the pupil as an M&M, and shaped like an M&M, except think of the outer coating, the green or red color of the coating as with a lens, think of it as a bag of cellophane. And then with an M&M, you have inside the coating the chocolate. Well, inside that cellophane wrapper, which is referred to as the capsule, is the lens contents. And together that forms the lens and bends the light rays. And of course, as lenses are supposed to be, the human lens is clear until you hit around your 50s, and then it starts getting that yellowish kind of discoloration, very slightly at first, and then gradually increases to a more of a orange and even an amber kind of color. And also there can be white, grayish kind of discolorations in the lens as well. So to access the lens, first a cut is made in the front part of that lens and grasped, and a circular tear is performed on the front part of the lens, approximately 5.5 millimeters in diameter, to allow access to the contents of the lens. Right, so we're making a circular opening in the front capsule of the lens, and then the ultrasound device is passed through a tiny incision that's made with a microscopic scalpel, making that 2.5 millimeter incision, and that incision is usually made near where the colored part of the eye hits the white part of the eye. And so the ultrasound tip has access to the contents of the lens, and the ultrasound breaks up that contents into tiny particles which are aspirated out through that same tip. So after the lens contents is removed, the patient is left with an empty capsular bag. And this, of course, has no power to it, and so the vision without very thick eyeglasses would be extremely blurry, because the natural lens is a very powerful lens. So what we do nowadays is place an intraocular lens made out of plastic, and we place that inside the capsular bag. Measurements are taken preoperatively, so we know what power to use, since every eye is different in that regard. The lens is a soft plastic that we could fold into a tiny cartridge that slips through that 2.5 millimeter opening, and the lens is then placed inside the capsular bag, where it unfolds once it's inside the eye. So the history of the intraocular lens is also very important with another pioneer named Harold Ridley. It was Dr. Ridley in 1949 came up with the idea of using an intraocular lens in cataract patients, because before then they were wearing those very thick eyeglasses, which had much distortion to it because of how thick they were. And how he came up with the idea was during World War II, when the British fighter pilots had injuries to their eyes from machine guns from other fighter planes that caused the plastic windshields to explode and enter the pilot's eyes. And Dr. Ridley, who was at a very prestigious hospital in London during the war, was operating on these soldiers. And what he noticed was that this plastic that was lodged in the eye sometimes for weeks, unlike other foreign bodies inside the eye, there was no inflammatory response. It just lied there. And he said, "Wow, that's interesting. Maybe I could use this type of plastic and use it as an intraocular lens for cataract surgery." And so then he went into the lab and started making these type of lenses using the same plastic that they used in the windshields of the World War II British fighter planes, which was called polymethyl methacrylate, abbreviated PMMA. And in fact, for decades, the intraocular lenses used that same type of plastic from the windshields of the British planes. Not literally from the windshields, but the same plastic used. And again, he was looked at as a heretic. He was kicked out of the hospital, but diligently worked on perfecting this. And again, the people who were against him had valid reasons. In the 50s and 60s, there were all kinds of problems with those lenses, again causing corneal edema. They displaced and fell out of position, but from die-hard surgeons, along with Dr. Ridley, they plowed forward for decades, and then in the 80s really started gaining steam. It took, again, decades, as I said, but finally was really perfected. And in the 90s, we started using the foldable implants for the first time, and that's when, at the same time, surgeons started adapting the phaco emulsification technique. Prior to that, the phaco emulsification technique only required that small incision, but the incision needed to be enlarged to put in the hard plastic implant. When the soft plastic foldable lenses came about, we were able to maintain that small size of the incision, and so you have the invention of Dr. Ridley and Dr. Kelman coming together in fruition boldly in the 1990s. So what should you expect soon after cataract surgery? There are a few restrictions, like no rubbing of the eye and keeping contaminants away from the eye. You can expect a mild foreign body sensation, mostly gone by the first day after the cataract surgery. And you can expect some blurriness that gradually improves over the first week. How about the risks of cataract surgery? With today's modern techniques, with a skilled surgeon, you can expect it to be at least 98% safe if there are no other problems that could increase the risk. The 2% that have some problem can usually be treated successfully, but not always. But there is backup in case there was a problem. There definitely is backup, and most of those patients end up okay. But 98% of the patients, at least, it's clear sailing. And when do the benefits outweigh the rare risks? As we had discussed earlier, the time to do that is to have cataract surgery is when the vision is blurry enough that it's interfering with the things that you want to do. Remember, the cataract doesn't stay like it is. It always progresses. And if you wait too long, it could make it more difficult to remove it. But if it's not bothering you, you leave it alone. But it's nice to know that it's extremely safe surgery in a skilled surgeon's hands. Not all cataract surgery is the same. These days, surgeons use phacoemulsification to remove the cataract and replace it with a clear plastic lens called an intraocular lens. But there is a wide variety of techniques available that you should be aware of. Again, not all cataract surgery is the same. There's eye drop anesthesia, known as topical anesthesia, versus a needle injection, known as a block anesthetic. There's laser-assisted cataract surgery, which is relatively new, which is combined with phacoemulsification, versus traditional phacoemulsification. And then there's the techniques to try to minimize your need for glasses after cataract surgery, and you have so-called premium intraocular lenses versus blended vision. Let's first talk about topical anesthesia versus block anesthesia. Of course, we want to numb the eye for the cataract surgery so you feel no discomfort. And we can do that with simple numbing drops instilled in the pre-op area, and your eye is nicely numbed. Or you can have a needle injection in the region around the eye that numbs up the entire area, including the eyelids, the eye muscles, and the eye itself. And those are the two techniques that are available. Let's talk a little bit more about that. The American Society of Cataract and Refractive Surgery, known as ASCRS, performs an annual practice patterns survey, and as far as topical anesthesia goes for cataract surgery, they looked at that and continue to look at that every few years. In 1993, when it was a new technique, 11% of surgeons were reported to be using that technique then, and all the rest were using the block anesthetic. By 2000, it really zoomed up to 50%, and in 2012, there was 75% of the surgeons were using topical anesthesia. Why is that? Well, we can look at the advances in technology, which has been a major driving force enabling topical anesthetic to be used for cataract surgery. The phacoemulsification technique and the foldable intraocular lenses have led to small sutureless incisions with less surgical time and tissue manipulation. So improvements in technology have made topical anesthesia possible. What has motivated the switch to topical anesthesia? Well, first there's patient satisfaction, and then there's surgeon satisfaction. From the patient's view, they have an immediate post-op bilateral functional vision, i.e. no patch on the eye. With the block, you're numbing the eyelids, and so afterwards the eyelids would just droop open and the eye would get all dried out. And so at the end of the case, we just gently close the lid and place a patch over it so it stays closed, and then that's removed about 4 to 6 hours later. Some surgeons leave it on commonly all day and remove it in the office at the first day post-op visit. But with topical anesthesia, there is no patch required, and you're just up and at it. Patients also like that there's less sedation, so faster recovery afterwards. You know, with the block anesthetic, it hurts, and so you need to be put to sleep for about 10 minutes with the IV sedation, and then the injection is given, and then 10 minutes later you come out of it. No surgery's been done yet, but you're all nice and numbed up. The lids don't blink, the eye doesn't move, and the eye's all numb. With the topical anesthesia, the eye drops don't hurt, and so you certainly don't need deep IV sedation for that. But some patients commonly like a little bit of sedation through the IV for the topical surgery just to take the edge off of things, but it's mild. Now also, you're going to have less swelling and redness, and no black and blue marks on the eyelids with the topical anesthesia. With the block, you're getting an injection. Commonly, you'll have a black and blue mark, and very commonly, the eye is going to be red, a little swollen. With the topical anesthesia, when the patient leaves the OR and someone is there to take the patient home, that person really can't tell which eye I did the surgery on by looking at the patient. And then finally, there's no fear of pain from the block anesthetic. Some patients harbor some fear of that. But remember, when you're getting the block, you at least put to sleep for 10 minutes so that the injection won't hurt because you're asleep. Now, also there's this, as we said, the surgeon's satisfaction. Why are the surgeons been motivated to switch to topical? From their perspective, it's because of the decreased risk from the needle injection and deep IV sedation. Of course, we like that the patient likes the idea of having it, but we're thinking of some rare but serious potential risks with the block. You see, with the block anesthesia, it's a blind procedure. The needle is injected into the socket, and it requires very accurate placement of that needle, and it's in a small space surrounded by delicate structures like nerves and blood vessels. So it's not a matter of if, but it's a matter of when a complication will occur from a block. The goal of the block anesthetic, as we said, was anesthesia to numb the eye, and also akinesia, a temporary paralysis of the eyelids and ocular muscles, so you can't blink, squeeze, or move the eye. With topical anesthesia, the eye is numbed, but there is no akinesia, so the eyelids can blink, the eye can move, but the eye is nice and numb. So let's put topical anesthesia and a block anesthetic head-to-head here in different aspects. First, with topical anesthesia, the drops are not painful, and with the needle injection, that's quite painful. With topical, only mild IV sedation is used, if at all. And with the needle injection, because of the painful aspect of it, deep IV sedation is required to put the patient to sleep while the injection is given, and so then they don't feel the pain of that. As far as drowsiness goes, because there's only mild, if any, IV sedation with the topical, only mild drowsiness occurs with topical anesthesia, but more significant drowsiness afterwards with the IV sedation. I mean, with the IV sedation, deep IV sedation for the block. How about pain during surgery? Well, there's no pain during surgery with topical, and there's no pain during surgery with the block. With topical, there's no redness or swelling of the eye, like we said, but with the block, it's common for the eye to be red and swollen after the surgery. And same thing for the eyelids, no unsightly bruising for the lids with topical anesthesia, but it's common to have black and blue type lids after the block. As we said, no patch is required after topical, but an eye patch is required after a block. There's minimum risks from the mild sedation with topical anesthesia, but there is some risk with the deeper sedation given for the block, such as aspiration pneumonia, and it's always good to have on hand skilled and experienced anesthesia staff monitoring the patient when they're having a block. There's no breathing risks with topical anesthesia. You're just getting numbing drops. But there are some rare but very serious risks with the injection where the needle anesthetic can track up from the socket around the optic nerve and actually get to the breathing center of the brain. The patient can stop breathing, and with a skilled, experienced anesthesia crew, they just help the patient along during that until that numbing medicine wears off and the patient can breathe on their own again. Again, very rare, but it can occur. Then there's also the question of damage to the eyelids, where numbing drops is not going to do anything to the eyelids, but there is risk of the needle injection, which is being used around the eyelids to numb them, to have some permanent drooping of the eyelids. Again, not common, but it can occur. Also, no problems with double vision from the numbing drops, but the needle injection traveling through the socket can sometimes damage the muscles around the eye, causing double vision that could last sometimes just temporarily, but sometimes for long periods of time, and occasionally it needs muscle surgery, eye muscle surgery, to resolve. Again, that's not common, but it can occur. As far as numbing drops go, you're not going to get bleeding in the socket, but it can occasionally occur with the needle in the socket nicking a blood vessel, that you can have a serious bleed in the socket, that usually all that is required is to postpone the surgery and let that resolve and come back weeks later and then do the surgery. Sometimes there's so much pressure built up from the bleed in the socket that some releasing incisions are needed around the eyelids to relax the pressure that's forming on the eye. Rare, not common, but it certainly can occur. And numbing drops are not going to do any ocular injury, but again, with the needle injection, the needle traveling through the socket, sometimes the needle can actually puncture the eye itself and cause a very serious retinal problem. Again, another rare occurrence, but that can happen. So in 1991, topical anesthesia use began, and by 2012, 75% of Ascaris members were routinely using topical anesthesia. I began routinely using it in 1997 when it became apparent to me that it was a safer procedure to use for most patients. Today I do topical anesthesia on 80% of my patients. 20% who have other aspects that I know will make the surgery more complicated in advance, I'll use a block anesthetic. In that case, I think the benefits of the block outweigh the risk, but in the vast majority of patients, topical is the preferred mode of anesthetic that I and 75% of the Ascaris member surgeons prefer to use. Today in Richmond, you need to understand it's a bit of an aberration, since less than 10% of the cataract surgery being performed is being performed with topical anesthesia. I cannot exactly say why, because it's unusual, that less than 10% statistic, but that's the case. If you have a doctor who's planning to do cataract surgery for you, you should at least discuss those aspects of anesthesia and to inquire whether they're going to use topical or block and the reasons why. But at least now you have some understanding and some background knowledge so that you can understand that discussion at a higher level. When it comes to cataract surgery, laser-assisted cataract surgery versus phacoemulsification is a hot topic amongst surgeons. I happen to be one of the world's leading authorities on this controversy. Recently, the Ascaris International Journal chief editor interviewed me about this. Just to give you a little background, here's what he wrote in the introduction to his article, was this: reviewing the many studies on this technology is no easy endeavor, and I marveled at the thoroughness and the objectivity with which he independently undertook this project. He's referring to me. All ophthalmologists have the capability to do this, but I am not sure that anyone else has. Because of the favorable cachet that patients attach to laser cataract surgery, it is easy for surgeons in competitive markets to be influenced by fear. Our patients, however, trust us to employ our medical and scientific training to ethically and objectively decide what is best for them. I applaud Ken for striving to do just that and for being willing to share his exhaustive research effort with the rest of us. So let's look at this. The laser-assisted cataract surgery utilizes a high-speed laser called a femtosecond laser. So it's abbreviated FLACS, femto laser-assisted cataract surgery. The laser can be used to create the micro-incision in the eye that we talked about for phacoemulsification. And then it can be used to create the opening in the front of the lens, the circular opening that we talked about, so we can have access to the contents of the lens to dissolve with the ultrasound device. And then it can actually soften that lens contents so less phacoemulsification energy is needed. So let's look at the case for FLACS. The idea put forward by the manufacturers and their consultants is that the laser creates a more precisely sized and circular capsular opening, so perhaps it holds the implant in a more perfectly centered position in the eye and therefore results in less of a postoperative refractive error, such as nearsightedness, farsightedness, and astigmatism. In other words, less need for glasses because the implant is going to be somehow better centered within the capsular bag because the circular opening made in the front of the bag was more round and centered. And then the second thing they talk about is that less ultrasound energy is required since the lens contents are softened by the laser, and therefore you may have less postoperative corneal edema. And if you have edema in the cornea, that's almost always just temporary, but it could cause some foggy vision in the beginning, and so this way you may have a faster visual recovery if less energy is used. Very rarely there can be permanent edema in the cornea, and the claim would be perhaps there would be less of an incidence of that as well using the laser to soften the contents first. How about the case against FLACS? Well, they talk about a perfectly centered and very round capsular opening, therefore leading to a better position of the implant and therefore leading to better vision, either with or without glasses. So you see in the upper right section here, these are the capsular buttons that were removed after it was torn manually by the surgeon to make the opening in the front part of the capsule, and you can see they're somewhat irregular. And down below you can see that they're perfectly round. These, of course, have been dyed blue for easier visibility. But the interesting thing is study after study has not shown any evidence that the vision is any better with or without glasses. We know that less ultrasound energy is needed with the FLACS technique because the contents of the lens are first softened with the laser prior to doing the phacoemulsification of the contents. However, numerous studies have shown either no decrease in corneal edema or maybe a very slight and temporary decrease. And one recent study showed a significantly greater amount of corneal edema with the FLACS technique when the 2.5 millimeter surgical incision is made with the laser instead of manually. One very alarming aspect to the FLACS technique is illustrated by these electron microscopic views of the edge of the capsular opening that was torn, that they say is so much rounder and centered. And that edge looks nice and looks round, like we showed you, to the naked eye, and even under the operating microscope to the surgeon. It looks very nice. But when you have a closer view with an electron microscopic view, it shows a dangerous-looking rough edge. The lower two right electron microscopic views of the edge of the capsule are those capsules that were torn manually by the surgeon with the traditional phaco technique. But all the rest show the roughness, the ridges, the tags at the edge of the capsule, and that has clinical significance. What studies have shown is that there's a learning curve danger. For surgeons learning this technique, at least the first 100 cases have a much higher complication rate due to tearing at the site of those ragged edges. And even after the learning curve, studies have shown a significantly higher complication rate even for experienced users due to these edges tearing. As for making the entry incision with the laser, they are more ragged than the manual incisions, just like the capsular edge openings made by it. And as we discussed, it creates more corneal edema. The flax technique also adds about at least 25% more time to the procedure. And then there's the cost of flax. The laser costs $500,000. $50,000 a year approximately for maintenance of the laser, about a $350 charge to the surgeon every time it is used for each eye. And the surgeon has to pass the extra charges on to the patient. And so there's a considerable out-of-pocket expense for the use of this laser passed on to the patient. So at least in its current state, I like to say about flax that it's not a revolution as marketed to eye surgeons. It's not an evolution. It's really no solution at this point. Whether or not eyeglasses are needed after cataract surgery is an important topic. The first goal of cataract surgery is just to get you to see clear again, whether you're wearing glasses or not. The second goal, though, is while the surgeon is at it, there are various things that can be done during the cataract procedure to either reduce or eliminate your need for eyeglasses, and to do that would be the second goal. Insurance covers general cataract surgery, but it doesn't cover refractive cataract surgery, those techniques and tests that are done to reduce the need for eyeglasses after the cataract surgery. So there will be out-of-pocket expenses for those extra things done at the time of surgery to minimize your need for glasses post-operatively. Some patients don't mind wearing glasses, but the way I view it is our job to educate you to understand what it's like to be wearing the glasses after cataract surgery, seeing clear now that the cataracts are gone, versus seeing clear even without glasses. And then it's up to the patient to decide the relative value for that. So to help educate you about this, let's try to first explain refractive errors such as farsightedness, nearsightedness, and astigmatism. These are conditions that are correctable with either glasses, contact lenses, LASIK or PRK, generally referred to as laser vision correction, and or cataract surgery. In the nearsighted eye, the cornea and lens are too strong for the length of the eye, so the light comes to a focal point before it hits the retina, and thus the images are blurred. In the far-sighted eye, the cornea and lens are not strong enough for the length of the eye, so light comes to a focus behind the retina, and again images are blurred. With astigmatism, the cornea is oval instead of spherical, creating two focal points and thus blurred vision. Usually some astigmatism is tacked on to whether or not the patient is nearsighted or farsighted. And then there is presbyopia, or the loss of accommodation. The focusing muscle in the eye changes the shape of our lens to help us focus on near objects. That's referred to as accommodation. This ability gradually decreases after age 40. Even if you do not have nearsightedness, farsightedness, or astigmatism, near vision becomes increasingly blurry after age 40, and again that's called presbyopia. The limitations of standard intraocular lenses that are covered by insurance do not correct astigmatism. and the shape of those lenses cannot be altered by the focusing muscle, thus causing presbyopia. For astigmatism, there are two options to correct it at the time of cataract surgery. First one being limbal relaxing incisions, or LRIs. Here, one or two tiny relaxing incisions are made at the edge of the cornea at the time of cataract surgery to round out the oval shape of the cornea to decrease the astigmatism. The second option is a toric intraocular lens. This special intraocular lens has the astigmatism correction within it. If the patient chooses to have their astigmatism corrected at the time of cataract surgery, prior to the cataract surgery, we make very careful measurements of the astigmatism, and that helps me determine which of the two techniques I would recommend. What about the role of laser vision correction, like LASIK or PRK, at the time of cataract surgery, or actually usually somewhat after the cataract surgery is done? Let's say that even though very careful measurements are made preoperatively, as we discussed, to help the surgeon calculate the best power intraocular lens to use for the individual patient, the measurements are not 100% accurate. We have the most state-of-the-art instruments to do those measurements, and they're very accurate, but not 100%. And so, postoperatively, if some significant residual nearsightedness or farsightedness or astigmatism remains, the patient can elect to fine-tune things with laser vision correction. And with laser vision correction, we can very accurately shape the cornea, not the intraocular lens, to reduce or eliminate the need for glasses. And your cataract surgeon, therefore, should be skilled in laser vision correction as a backup. I think that's really important. So when choosing a cataract surgeon, you should also be choosing someone who's skilled in laser vision correction, or at the very least can refer you to someone who is. But let's keep in mind, for those people who don't mind wearing eyeglasses after the cataract surgery, the fact that they may have some residual nearsightedness, farsightedness, or astigmatism can always be corrected with eyeglasses. But for those who find that it's important for them and place value on the fact that they can reduce or eliminate the need for glasses, all these things that I'm discussing are important. So remember, the first goal of cataract surgery is just to see well with your glasses. The second goal is, while we're at it, we'll try to minimize your need for glasses. If you have astigmatism, we can correct that. And we can also try to make it so that not only can you see well at distance without glasses, but also at close. What I'm referring to now is the correction of presbyopia. And there are three options to do this: blended vision, multifocal intraocular lenses, and an intraocular lens known as crystal lens. Let's take a look at these three options. With blended vision, what we're doing is taking the dominant eye, and which eye is dominant is a brain thing, not an eye thing, but one eye is more dominant in the brain than the other. And so preoperatively we determine which eye is the dominant eye, and we take that eye and set it for distance. And the non-dominant eye will set for near, without glasses. We set it so there's not too much of a difference between the eyes, so the brain can easily blend the two images together. The priority is on the distance vision, and we'll try to give as much near vision without glasses as we can get away with, but yet still having you see comfortably and have excellent distance vision. So to do that, again, priorities on the distance vision, and we're targeting for the non-dominant eye more computer, intermediate range, than sitting down and reading a magazine, even though you probably can do that, but it would be easier to wear a small power drugstore reading glasses for smaller print and in dimmer light. Another option is the multifocal intraocular lens. Here, half the light entering the eye through that multifocal intraocular lens is targeted for near, and the other half of the light is targeted for distance. Unlike with blended vision, instead of using a multifocal intraocular lens, we're using what we call a monofocal. All the light is targeted at one distance. You set it for distance or you set it for near. But with the multifocal intraocular lens, half the light in the same eye is going to distance and half is going to near. So each eye is seeing far and near. You get excellent near vision for small print with this approach. There is some difficulty, however, seeing at an intermediate range, such as with computers, because the near vision is set so you have to hold the material a little bit close, and you find yourself sometimes uncomfortably needing to come close to the computer. The other downside of the multifocal intraocular lens is that there is good distance vision, but it compromises the quality of vision, such as severe halos and poor contrast sensitivity. How about the crystal lens? This is a monofocal lens, but it is made so there is a little bit of movement to the lens when you're focusing at near. So, as it says here, it moves a little more from the action of the focusing muscle than a standard intraocular lens. Therefore, this movement gives some more intermediate vision than a standard intraocular lens, but not as good near vision as a multifocal intraocular lens. All the light is focused on one point because it's a monofocal lens, so there's no decrease in contrast sensitivity, but some patients experience severe halos. So what does the research show us when you put the different techniques head to head? Myself and my staff painstakingly collected data to evaluate this, and this was presented in 2011 to the large annual meeting, international meeting of the American Society of Cataract and Refractive Surgery. And here's what our results showed. With near vision, like books and ingredients for a recipe and that kind of thing, blended vision this is without glasses, using both eyes, they were seeing 20/25, which is very good, close to 20/20, reading near vision. With intermediate vision, they were seeing incredibly well, better than 20/20. This is at the computer, 20/18. So decent near vision for, let's say, a magazine, and excellent computer vision. With the multifocal intraocular lens, both eyes are set for distance, but each eye can also see it near, and they have excellent vision at near, as we had said. They're seeing just about 20/20 reading small print, but they drop off at close to 20/30, less than 20/25 at intermediate range for computers. The crystal lens doesn't have that great a near vision for, let's say, reading a magazine, 20/32, not as good as blended vision. Why? They're both monofocal lenses. Why is blended vision better for seeing at near, such as magazines? Because one eye is set for far and one eye is set for intermediate, but that also gives a decent ability to see near, like magazines. As I said, with blended vision, plan on wearing drugstore reading glasses for the smaller print, just to make it a little easier. And many of the crystal lens patients, where that lens has some movement to it, so if you're setting both eyes for distance and relying on that movement to see at close, it's a fair result at 20/30, but very good for intermediate for computers, but that they definitely drop off for reading magazines in smaller print and in dim light. Therefore, much of the time the surgeon needs to take that crystal lens and also give a little bit of blended vision, setting the dominant eye for distance and the other one making a little nearsighted so they can see up close a bit better. But then you'll see the crystal lens costs so much more than when you're having standard blended vision, which is what I recommend. And so why spend all that extra money if you still end up doing blended vision? Kind of interesting. So let's look a little bit more at this.
more than just what size letters you read on a eye chart. Really the more realistic way of measuring the ability to see up close is with reading speed. When we tested people reading speed of newspaper-sized print, we had an interesting result. You need to know that 80 words per minute is the lower limit of comfortable reading. That's the standard for this research that has been set before. And so if you go to 80 words per minute or less, that's not very good. So look here, with blended vision, the patients were seeing newspaper-sized print 179 words per minute, which was very good. Multifocals, as I said, do fantastic at near, have a little trouble at intermediate, and then the crystal lens, look, below 80 words per minute. And so again, with crystal lens, you probably have to combine it with blended vision. Okay, so we have seen that the multifocal lens does really good at close, and some patients may require the ability to see very small items and read it very fast, and don't mind some difficulty seeing the computer or moving up a little closer to the computer, and that may be a fine option for them. But there are some problems with the multifocal IOL in the quality of vision, and because of that, we see that only 94% of patients are fully satisfied with the multifocal lens. When we ask, would you have the procedure again, it's 94%, but with blended vision, 100%. Again, 100%, but they have realistic expectations beforehand that they're going to require some very low-power drugstore reading glasses for a little extra boost some of the time, but most of the time they're glasses free. With that realistic expectation in mind, going into it, 100% of the patients were satisfied, but you had some frustration with the multifocal. And again, with the quality of vision, we see with blended vision, night vision, did they have any extreme difficulty, we asked, and 0%. Did they have any difficulty driving in difficult weather? 0%. But with the multifocal implant, it's 2% with extreme, this isn't some difficulty, this is extreme difficulty. 2% say they have extreme difficulty with night vision. And 2% is 1 out of 50 patients, not like it's 1 out of 1,000. And then you have driving in difficult weather. Look at that, 4% with the multifocal. With the crystal lens, what's been reviewed is the night vision, and that was 2%, very similar, extreme difficulty driving at night as to the multifocal. So you can see here, with 0 severe complaints with blended vision, that's why there's 100% satisfaction. Now, I'm hesitant to say 100%. I'm sure there's somebody who might have some trouble, but we just haven't seen it when the targeted goal of the end prescription, the dominant eye set for distance and the non-dominant eye set for the computer, when that's reached, 100% is what we've seen. And remember, in those occasional cases where that's not obtained, that could always be perfected with laser vision correction afterwards. Now look at this. With blended vision, simply setting the dominant eye for distance, non-dominant eye for the computer, $350 per eye is what I charge. Multifocals, the going rate is about $2,000 out-of-pocket expense per eye, and the same for the crystal lens. Therefore, I feel strongly that the best option for seeing without glasses after cataract surgery is blended vision. Gives excellent quality of vision, excellent intermediate vision at the computer, good near vision with the magazine, but you may need a small power drugstore reading glasses to make it even easier. And it's much less expensive than the alternatives. Now, it's not to say that some patients who've had a multifocal or crystal lens are not happy, and there may be a good choice for some patients, but for the majority of patients, I recommend blended vision. This section on cataract surgery refers to men, whether you already have a cataract or not. And it deals with the
syndrome that we call BPH, or benign prostatic hypertrophy, which has to do with the fact that the prostate enlarges as you get older. And it's common when someone is over age 50, if you're male, because of BPH, to find that you have increased urinary frequency, and it can become annoying having to wake up in the middle of the night to use the bathroom. And so what has become very common is to use a class of medication called alpha antagonists, which relaxes smooth muscle, and it relaxes the smooth muscle around the ureter so that there is less frequent urination. The most popular and strongest one of this category is called Flomax. There are several other varieties, other brand names of alpha antagonists. And what alpha antagonists do is cause atrophy of the iris muscle, the colored part of the eye, inside the eye, and the opening in the iris muscle we know is the pupil. So it causes poor pupil dilation and something called floppy iris syndrome during cataract surgery. And this significantly increases the risk of cataract surgery. When you look at someone who's been on Flomax for a while, and remember, usually when you go on this, you stay on it. And so if you've been on this more than just a few months, the iris in many of these patients will start looking almost moth-eaten, very thin and atrophic. And when you enter the eye with the phacoemulsification device, the iris becomes billowy, and that's what I call the floppy iris. And the iris will tend to come right outside that 2.5 millimeter incision and get in the way of the phacoemulsification tip, and it really causes things to be more complicated, increasing the risk of the cataract surgery. The important thing to know is that discontinuing the medication prior to surgery does not reverse the problem. So the main thing is not to go on the medication. Urologists and primary care doctors invariably will not warn you about the floppy iris syndrome. A recent study was done that showed how few primary care doctors even know about the syndrome after the researchers who discovered this syndrome, which happens to be Dr. Chang, who interviewed me for that article about femto LASIK cataract surgery. Dr. Chang has written numerous articles and gotten them into the primary care peer-reviewed literature as well as the urology literature. But it appears, despite that, it hasn't made much of a dent. Few primary care doctors know about the syndrome, and even less act upon it. Similar, the urologists do somewhat better, but it is less than a third are actually telling patients about it, according to his study. But my experience, lots of experience for years in Richmond, as far as I know, nobody is told about the possible problem of floppy iris syndrome when they're put on alpha antagonists for BPH. Now, if Flomax or other prostate medications are needed, not just for convenience of not waking up in the middle of the night to pee, but medically necessary, in other words, you run the risk of severe urinary retention, then you know, if you need it, you need it. So then in that circumstance, what do? First, a skilled surgeon can work around it, although the risk is still increased. You could have cataract surgery prior to starting the medication. You can use another category of medication that does not cause floppy iris syndrome. One such brand name is Avodart. It's not an alpha antagonist, and it helps shrink the prostate. It doesn't relax the smooth muscle around the ureter. It actually shrinks the prostate. It takes a little longer to kick in, but can be very effective. Or you can use a non-selective alpha antagonist. The Flomax is the strongest because it's what they call a selective alpha antagonist, but there are other varieties such as uroxetrol, which isn't as powerful, and it still can cause floppy iris syndrome, but not as commonly and maybe not as severely. And then you can consider having laser surgery of the prostate for BPH instead of medical treatment.
We have now come to the end of the cataract discussion. I hope you found it interesting and informative. Let's look at a few of the take-home messages. First, if we live long enough, everyone will need cataract surgery. Cataract surgery is very safe and effective in a skilled surgeon's hands. However, not all cataract surgery is the same. There's topical versus block anesthesia, and 75% of American Society of Cataract and Refractive Surgery members use topical anesthesia today. In Richmond, less than 10% of the cataract operations are performed with topical anesthesia. Femtolaser-assisted cataract surgery has no clinical benefits, as far as I can see, as far as the scientific literature has shown to date. Possibly there are higher risks of capsular tears with flax, and it costs much more. As far as decreasing your dependence on eyeglasses, I highly recommend it. You should seek a doctor who can back up refractive cataract surgery with laser vision correction. Blended vision is much less expensive, and the results are just as good, if not better, than that with crystal lens or multifocal intraocular lens, and it avoids severe visual quality issues. Flomax is a medication used for benign prostatic hypertrophy in males, and your doctor who places you on it will invariably not inform you of the risks associated with it and cataract surgery. However, now you can inform your doctor. Call us if there are any questions. We'd be happy to see you and talk more with you. You can reach us at 804-288-1543, or you could schedule an appointment right here at our website at our online scheduler. Thank you again for taking the time to listen to this and watch this PowerPoint. Again, I hope you found it interesting and informative, and I hope you are now empowered enough to ask the right questions going forward. Thank you again.